welcome to this episode of the BSR's Rheumatology Roundtable. And today we're going to be speaking to the authors of the updated BSR guideline for conventional synthetic DMARDS. I'm Ernest Choi, Editor-in-Chief of Rheumatology Oxford, and I'm going to ask all our speakers to introduce themselves, starting with Louise.
Hello, I'm Louise Mercer. I'm a consultant rheumatologist at Stepping Hill Hospital in Stockport, and I've had the pleasure of chairing this guideline working group.
Katie.
Hi, I'm Dr. Katie Bechman. I'm a consultant at King's College Hospital and a senior clinical lecturer at King's College London.
Akhila.
I'm Akhila Kavirayani, a consultant pediatric rheumatologist at Oxford University Hospitals, and I represent the pediatric subsection of the csDMARDS GWG.
Alan.
Hi everyone, I'm Alan Davidson. I'm a clinical nurse specialist working in adult rheumatology in community in Birmingham, and I've been representing the nurses on the group guideline.
Last but not least, James.
Hi, I'm James Galloway. So I'm a adult consultant rheumatologist in King's College Hospital and professor of rheumatology, and was the chair of the previous guideline and a member of the guideline work group here.
Welcome, everyone. So in this episode, we're going to provide a summary of the key take-home messages from these updated guideline and how it can help clinicians to manage patients taking these medications. So I want to start off with Louise. Can you start by giving us an overview of the guideline? Why was an update needed and what is new about this version?
Thank you. Yes, we needed an update because the previous version actually went back to 2017. And that was a very important guideline at its time. It introduced for us for the first time hydroxychloroquine and retinopathy monitoring and also harmonized blood monitoring. And we will build on these areas in this current guideline. I think probably the most important thing to start with is the fact that this new 2025 guideline includes the whole life course, so children and adolescents as well as adults. And as part of the guideline working group, we've had pediatric rheumatologists, pediatric pharmacists, and also specialist nurses. So we could try and make guidelines where possible that were harmonised across the life course. The guideline also reflects several changes in clinical practice since 2017. We're all used to seeing new biologic drugs, of course, but new DMARDs don't come along very often. But we're very happy to include voclosporin as a new csDMARD in this current guideline. There's been significant advances in evidence around vaccines in people with rheumatic diseases, particularly in relation to optimising responses in people taking methotrexate. And this, of course, includes the COVID vaccines and studies, which wasn't even on the horizon back in 2017. Along with this, there's been changes in the general population health. I think overall, on average, we're becoming less healthy in some ways with more obesity and more fatty liver diseases such as MASLD, previously known as NAFLD, which now affects up to 30% of our general population. And this can be quite challenging for our patients and care providers in relation to safe prescribing and monitoring of DMARDs, for example, when we pick up raised liver enzymes. And for this updated guideline, we wanted to look at a more risk-adapted approach to prescribing and monitoring our drugs.
Great. James, since there is a need to update this because of changing in patient risk factors, new medications, new clinical circumstances, and new practice, how was the guideline developed?
Yeah, so the guideline, in sort of line with guideline development methodologies and the other BSR guidelines, it's an enormous amount of work going back over several years. These guidelines take huge amounts of effort. Firstly, to map the scope of the guideline, and we have a scope document that was published to bring the stakeholders together to then craft the questions and to do the literature searching and the evidence review. And I think it's really important to remember that the guidelines are not just about the evidence, but it's also about expert consensus around that evidence. The DMARD guideline is an area where there are pockets where there is an absence of evidence to build upon. So this is about a multi-stakeholder project providing evidence-based recommendations and expert opinion around how we can best safely prescribe DMARDs.
Katie, can you give us an overview of some of the key recommendations people can find in the guideline, especially how they may differ from the previous versions?
Yeah, so these guidelines certainly have a greater emphasis on screening for infection before starting csDMARD therapy, and several new recommendations have been added. And these include screening for latent TB in individuals who are at risk, screening all adults for hepatitis B, hepatitis C, and HIV, and checking varicella immunity in all children and in adults who have not had prior infection or previous vaccination. And this greater emphasis on screening really reflects the rising prevalence of some of these viral infections in the UK, the national shift towards opt-out screening, and the availability of effective antiviral therapies. And the aim is to prevent severe complications that may occur if undiagnosed infections are present when immunosuppression is started. And just to reiterate that screening for infection should not delay the initiation of csDMARDS. The second new recommendation that we've introduced is also about screening, and this is about screening for liver disease in individuals, particularly adults, who are at risk before starting methotrexate. So the recommendation states that in those with risk factors, a non-invasive fibrosis score, which is the FIB4, should be performed, followed by a liver elastography, for example, a FibroScan. For those who are unfamiliar with FIB4, this uses variables that are collected in clinic, age, AST, ALT, and platelet count to estimate a fibrosis risk, which helps guide whether further liver assessment or referral is warranted. And given the risk for methotrexate-related liver disease in high-risk individuals, the guideline working group thought that it was essential to be screening and monitoring for this. And this approach in regards to the non-invasive fibrosis score is in keeping with what NICE recommends for screening for MASLD. But again, as we talked about with screening for infection, this should not delay initiation of methotrexate. The last recommendation that I wanted to discuss is a notable change to 2017, which is the relaxation of blood screening or blood monitoring for csDMARDS. And this reflects evolving clinical practice and some of the insights that we gained from the COVID-19 pandemic. And we now know from real-world experience that in selected patients, less frequent monitoring may be safe. And so the guideline working group recommends a risk-adaptive approach. So for the induction phase, when a csDMARD is started in individuals without additional risk factors for toxicity, monitoring blood should be checked at week 2 after starting the csDMARD, and then monthly for the first 3 to 6 months. And in individuals with risk factors for toxicity, more frequent monitoring is advised. In the maintenance phase, in individuals without risk factors for toxicity, maintenance blood should be carried out at 3 monthly intervals. However, this interval can be extended following an individualized benefit risk assessment. And really, we feel this recommendation balances patient safety with practical, sustainable care. I'm going to hand over to Akhila now, who's just going to talk through some of the differences between the adults and children within this guideline.
Thanks, Katie. First of all, I highly commend the BSR initiative to include children and young people within the same guideline framework. And thank you so much for this opportunity. And it's a privilege to speak on behalf of the pediatric group. I think it's important to remember that children are not small adults. It's often quoted, but it's a very true statement. Some of the key differences for children and young people in this guideline are some of which Katie has already alluded to. But just to make it clear, there is clear guidance on blood monitoring, including specific tests. For example, testing for varicella and measles is in all children at baseline, which is in slight variance to the adult recommendations. Again, we have addressed frequency of monitoring, accounting for practical problems with phlebotomy in young children. For example, the week 2 test is optional in children in this guideline. We've given additional information on interpretation of abnormal results, which is in a clear table format alongside the adult guidelines. And we encourage shared care with primary care providers, all whilst ensuring support, strong support, in fact, from the tertiary pediatric rheumatology centers. Also, due to differences in comorbidities between adults and children, certain scoring systems or investigations are less relevant in children, such as FIB4 or the FibroScan. And baseline testing for hepatitis and HIV is not routinely recommended when commencing csDMARDS in children, unless, of course, it's clinically indicated. We also have to remember some medicines are not routinely yet used in pediatrics. For example, voclosporin, minocycline, and apremilast is not licensed or approved for use in children apart from in ongoing clinical trials. Thank you.
And why do you think it is important for this guideline to be expanded to include the whole life course?
Thank you, Ernest. So covering the whole life course enables seamless transition and thereby effective transfer of care. And it is a more cohesive and joined up process between children and young and the adult services, which has a multitude of advantages in all facets of effective disease management. It not only empowers families and patients and children and young people, but also empowers clinicians across all tiers, including primary, secondary, and tertiary, bearing in mind that a select few clinicians are in fact life course rheumatologists. We, however, have to acknowledge and accept the fact that obtaining high quality evidence to guide recommendations in children can be quite challenging. In fact, to lessen ambiguity in this guideline, we have tried to carefully balance available evidence in children, including evidence that can be extrapolated from adult studies. We've derived information from existing international guidelines, including those from Europe or North America, and we've obtained expert consensus, including national consensus where applicable.
Fantastic. I want to turn to Alan. There are nurses involved in the guidelines development, including yourself. How do you think the updated guidelines will be used and help rheumatology nurse specialists in their practice?
Thank you, Ernest. So I think nurses have and will always continue to play a key role in supporting patients with their medications, where it's initiating those, monitoring those. So this guidance really helps give us clear evidence-based guidance and will enhance patient safety and provide consistency, which I think is really important up and down the country. But also, I think regardless of where you're sitting in primary care and secondary care, it will really help with that. This will go across the board, and also having the lifelong guidance as well. But I think recently, certainly in the last 5 years, COVID and beyond, but even prior to that, a lot of nurses, experienced nurses, are leaving. So we have a whole new raft of nurses coming in, which is really exciting, of course. But I think this will really help us now. We can use, and some of the things that perhaps mentioned later, the infographic is quite easy to see that. It's very clear, very concise, which I think would be great. But also there's an audit form, which also comprises a checklist, and I think for nurses that'd be really helpful. That can be used as a checklist. So those that are perhaps less experienced, but actually for all of us, this is new to us, and there are quite significant changes. So I think it's really good to have the guidance with us now and moving forward for the next generation of nurses coming in to us.
Great. James, we heard that why the update is necessary and there are important changes to screening and monitoring. How can listener find help to implement the guideline?
So I hope the guideline is it is accessible to users. The first thing is to say that obviously each of the individual statements, you can look at the individual statements and read those through as sort of a cohesive group, and that gives you the comprehensive view of each of the different steps. We've got some other tools though that are really useful. There's within the guideline document, and I'd really encourage people to explore it. There's some great tables. For example, the renal table has been updated and provides a comprehensive overview of prescribing renal disease. There's an infographic that's been mentioned. That the infographic is a really good summary of key changes and some headline findings. And there's also an audit tool in the guideline, which allow people to sort of take out the key bits and then say how are we performing against them at a local level. So I hope there's lots of things within the guideline, and there may well be people or listeners who create their own and maybe want to share those in due course, because I think there's lots of things that can be done with the framework from the guideline.
Thank you. And finally, coming back to you, Louise, what do you want to encourage listeners to pay particular attention to in the new guideline?
Thank you. Yes, and I think the overarching statements of the infographic, as Alan said, give a really good snapshot and introduction to what the new guideline is all about. And then, as James said, there's an absolute wealth of information under the surface. And I think that different readers will be able to dip in and pick out different bits that are important to them. For example, a patient rings about low neutrophil count. Well, there's now clear guidance on what we suggest you could do in that situation. Somebody wants to have a vaccine. What if it's a live vaccine? What if it isn't? So there's lots of areas in the guideline where there's some more detailed information that can inform those patient and clinician discussions.
So thank you very much, everyone, for updating us on the new updated BSR guidelines on csDMARDS. I hope all of you have enjoyed listening to the members of the working group. All the BSR guidelines and link resources are available from the BSR guideline page on their website. And I hope that you will join us in the future episodes of Rheumatology Roundtable. Thank you.